The other thing that you need to think about are all the various difficult situations that, again, nobody really tells you about, and you hope that never happens, but unfortunately will happen to somebody, if not you. Some of the stuff can be quite serious. So, needle sticks is an obvious issue with HIV, hepatitis B, hepatitis C, all that stuff. What's the protocol at your institution about handling needle sticks? Where do you go next? The meds they get you on. You got to know the policy. Abusive and inappropriate house officer. This unfortunately happens more often than not. Almost everybody will get into some sort of situation where if this was a regular office situation, like, I don't know, working at Staples or working at a law firm or whatever, this would not be tolerated. But, often a lot of this stuff actually happens in hospitals. So how do you handle that? How do you diffuse a situation where, somebody's inappropriate, but this person is also in a position where they're evaluating you without jeopardizing your own grades and so forth? Inappropriate procedures. So when it's inappropriate, what I mean is they ask you to do a procedure that you may not feel comfortable doing or you don't feel qualified or competent to do. So how do you handle that type of situation without losing face? Hyper-competitive classmate. It all happens. Everybody wants to do well. There may be quotas for, honors. For example, when I did third-year medicine at UCSF at the VA, we were told straightforward, third-year med students rotating through that hospital, but only 6 of us would get honors. And so it doesn't sound right, but those things happen. You do need to depend on your classmates, but when classmates can get out of hand, how do you handle the situation that keeps the camaraderie going and without really not making it a negative type of environment for everybody? Patient death. This is really hard the first time it happens. We all want to empathize, but sometimes we get really pulled into the lives of our patients, and that can happen. How do you deal with it? How do you deal with the emotion? How do you recharge after a difficult situation like patient death and keep it all level and straight? Sexual harassment, that's similar to what could happen because it often happens with members on the team. Again, how does that get handled? And so we go through some of these key situations in first aid of the wards and give you some basic advice. Some other things include difficult and violent patients. How do you maintain your own safety? Like if you're on the psych ward or if you're dealing with a patient who's sundowning. When I was a med student, our team admitted a patient who, and we didn't apparently check him well enough because he actually had an aged Bowie knife and when he sundowned, he apparently was going around the hospital with an aged Bowie knife, and we had to get security in to take him down. So these things can happen. Difficult family members. Their family members are sick. They may be dying or they may have died or seriously ill. It's very emotional for them. How do you communicate with them? How do you keep them well informed without going into emotionally charged areas? Narcolepsy, quote unquote. We all get tired, and I was no exception. If I didn't get a certain amount of sleep, I might doze off during attending rounds even or conferences and so forth. So if you're that type of person, how can you stay alert? Or if you know that there's no way of doing it, how can you be in a situation where if you do actually fall asleep, nobody's going to notice you doing it? And then, of course, personal family illness. Again, this is going to happen to a lot of us. We give some advice about taking care of your own family business, but also trying to stay in touch with the team a little bit or getting back early to catch up a little bit, etc. Those are some of the things that we cover. And again, it's not well discussed, but you need to be aware of these situations and have a little bit of an idea of how to approach it if something, unfortunately, like this were to befall you. So let's talk a little bit about how you can get off to a fast start once you finish your boards and you're transitioning now to the wards. A lot of you guys, of course, are going through your ward orientation stuff. You've already have probably passed test things, but hopefully you guys have thought through what specialties you're leaning towards. And if that's the case, you obviously don't want to do it as first or last block, especially as a last block, because if that's the specialty you want to do, then you want to be able to set yourself up for some sub-Is in that specialty. You want to be able to recharge between certain rotations. So, for example, medicine and general surgery don't really go well back-to-back. A lot of institutions know that automatically, and so they try to set up clinical tracks or third-year tracks where they kind of balance it a little bit. But you got to think about recharging, especially if you're going into a tough rotation that you're very, very interested in, such as general surgery, for example. And that takes me to my last other point, which is you might want to do an easy rotation before a special rotation. Some people, for example, favorite rotations to start off with. A couple of them, psych is a good one, not as super intense. You can build up good communication skills before you get to some of the other core rotations. OBGYN is another one. Not everybody wants to go OBGYN, but it's good because it gives you some medicine flavor and also some surgical flavor before you get into some of the other core rotations. choosing rotation sites. Every site has its own type of flavor, and again, you need to just kind of think about, how that affects you. The county type hospitals at UCSF or San Francisco General Hospital, very busy, semi-chaotic. You get a lot of indigent type patients coming in, lots of opportunities for procedures and hands-on stuff. VA is very similar, tends to be obviously more of a male-skewed older population. Again, at both, a lot of places, sometimes you're doing things on your own. Sometimes you're wheeling people down to nuclear medicine or radiology for studies and stuff like that because they don't have enough medical assistants to handle some of that stuff. Maybe you're putting in your own lines or drawing in your own blood stuff as opposed to having blood teams that do some of this stuff. Academic University Center tends to have more ancillary support, very, very academic, of course. You get some of the fascinomas that show up here, and on the downside, you may not get good representation of that specialty. You may not get some of the bread and butter stuff that you might see, quote unquote, in real life, which is kind of like the community private hospitals where you're going to see a lot more of this bread and butter stuff. You're going to see less of the fascinomas. And also here, perhaps downside is that private patients may or may not be as comfortable with you providing the direct care as opposed to, their quote unquote doctor. So that's, those are some of the trade-offs with a community/private hospital. Also, sometimes the experience and the expertise of the emergency room, the staff, especially on nights when, when a patient's going down big time, may not be as strong as if you're at a major center where when the ICU team comes in, these guys are pros and they're going to handle emergencies. More and more third-year clinical tracks include outpatient experience. We've always gotten it, but when I was a med student, I would say it was only like maybe 10, 20, 30% of my total experience, where, of course, as you know, the vast majority of us will be out in outpatient settings, but we're seeing a lot more of that as a trend at most major medical schools. There's obviously a different flow to how the patients come in for new evaluations and treating patients, and so it's fairly similar from field to field. So before the rotations, what do you need to do in terms of preparing? First, obviously, you're going to be talking to your classmates. Sometimes your school does this. They'll set up a panel, and the guys and gals ahead of you give you some feedback. Within first day for the wards, we have a specialty chapter for each of the core rotations. So for neurology, emergency medicine, internal medicine, peds, psych, general surgery, OBGYN, we have a chapter that's 30 to 40 pages that covers all the key topics that you need to know essentially on day one in terms of at least looking and being competent. We also tell you what the culture is and also what type of tools you may need for that particular rotation, what you need to have in your pocket. First aid step 2 CK is not considered a ward book, but a lot of students use that along with a first aid for the wards or as their primary wards book because they can kind of read through the chapters and, not only get ready for the wards in some ways, but also prep for the step 2. There is a lot of relevant content that you've learned in first aid steps, so a lot of you guys will keep your first aid step 1 with you and refer back to it very often as you kind of bridge from all that pathophys, so forth, to what's going on the wards. And then we have a huge section in the back where we have a set of recommendations for pocketbooks, medium-sized textbooks, hardback, software up to date, that type of stuff. And this is based on a national survey that we conduct every second or third year to get recommendation on what to do. We're doing more stuff now on PDAs, iPhones, so forth. So we'd recommend that you take a good hard look in that section as well too. At the end of the day, you want to understand that you've got a couple of things that you bring to the table that gives you an advantage. One is this is a very exciting time in your education, in your learning. You're going to be naturally enthusiastic. You should be able to bring a lot of energy and hustle to the team. Number 2, you're going to have more time per patient than anybody else on the team, per the attending who is perhaps overseeing 24 patients, or the residents that's seeing patients, or the intern who may have a census of 10 to 12 patients. You'll have more time to communicate with the family, more time to read up on the condition, maybe do PubMed searches to look up some key clinical reviews. Use that wisely. Of course, you've just taken the step 1, so you're going to come in with tremendous basic science knowledge. If you learn the information right, you should be able to apply this information right away in the clinical scenarios. And or if your med school did a good job in teaching you right, you should be able to apply it quickly. Finally, there's quote unquote, low expectations. We, as attendings and residents and so forth, often forget what it's like to be a third year, and that we just say, oh, well, they're a third year medical student. They don't even know where the bathroom is. And it's true. You're going to be on an extremely steep learning curve. But like I said, you're going to come in with all these other advantages that they may forget about. You'll be able to surprise them with how far you can go with workup of a patient, helping formulate a plan, thinking about what the next steps are and what the standards of practice or what's the best research is in that particular area. So again, use that to your advantage.